Welcome back to Einstein's Eyes, everyone. I'm Carl Rosen, oculoplastics and neuro-ophthalmology in Anchorage, Alaska, fellowship trained. I'm here with my friend and co-host, fellow former resident at Albert Einstein, John Ditkoff. John.
Hi, all. I'm a cornea specialist who also does general ophthalmology in northern New Jersey. Been doing that for 30 years, and it's a pleasure to see everybody.
Right. Again, thanks for being here. We're going to dive into a very exciting topic that bridges endocrinology and ophthalmology. We'll be discussing proptosis regression. In other words, when the eye bulges and it goes back after medical treatment with a drug called Tepezza, but it regresses and actually becomes proptotic again. We're going to talk about the percentage of folks that suffer from that. That's called proptosis regression after the treatment with Tepezza or teprotumumab. Teprotumumab. The mAb is a monoclonal antibody. It's a biologic agent. And this was described in a paper by Rosenblatt et al. In Ophthalmic Plastic and Reconstructive Surgery of this year, volume 40, pages 187 to 191, if you're interested. Here's the journal, Ophthalmic Plastic and Reconstructive Surgery. I wanted to highlight it. I thought it was a really fascinating article. So we're going to specifically focus on how Tepezza is making waves in treating thyroid eye disease, TED, or Graves' disease, also known as Graves' orbitopathy. We'll explore the study's findings, implications for patients, and what this could mean for future treatment pathways. So what is Graves' disease? Before we get into the study, let me give you a quick overview of Graves' orbitopathy. Graves' disease is an autoimmune disease that affects the thyroid gland, causing it to be many times overactive, usually overactive, but it can be underactive, sometimes even neutral. And that's called hyperthyroidism. The disease can lead to a range of systemic symptoms, including increased heart rate, anxiety, weight loss, personality changes. However, for some patients, Graves' disease can also cause thyroid eye disease. That's a subset, which affects the eye muscles and the tissues or the orbital fat within the confines of the orbit, which is the bones that surround the eyeballs. Now, the incidence of Graves' disease is estimated to be around 20 to 30 cases per 100,000 people per year. It affects women more than men and often manifests in patients between the ages of 30 and 50. So TED, or thyroid eye disease, is a subset of Graves' disease, can lead to symptoms like eye redness, irritation, double vision, and in severe cases, proptosis, which is also known as exophthalmos, or the bulging of the eyes, and in a very small percentage of people can even lead to blindness. That's a tiny percent. Now, the traditional treatments for Graves' disease or TED involves around managing the hormone levels through medications, radioactive iodine, sometimes surgery to remove the thyroid, and that's done by an endocrinologist or a general surgeon or ear, nose, and throat doctor. Many times, though, TED is managed with corticosteroids or steroids to manage the inflammation. And in severe cases, an orbital specialist or an oculoplastic specialist like myself will do something called a surgical decompression. And I do that with an ear, nose, and throat colleague or an otolaryngologist, and we get very good results. Now, enter Tepezza, a fascinating molecule, long journey to get this from the laboratory or the bench into the clinic, or teprotumumab. It's a monoclonal antibody that targets the IGF-1 receptor. That's also known as the insulin-like growth receptor. It reduces inflammation and swelling in the tissues behind the eyes, and this new treatment has brought hope to many patients, offering a non-surgical option for reducing proptosis or the bulging of the eyes and improving the quality of life for these folks. So this study by Rosenblatt et al. Investigated the effects of teprotumumab on proptosis regression. In other words, it got better and then it got worse again after treatment. Now, their findings were quite interesting. patients treated with Tepezza showed significant reduction in eye bulging, which is a very distressing symptom of thyroid eye disease. But they also found a significant proportion regressed or went back to the way they were. And even strangely, 26% got worse than before treatment. So that's a really interesting finding. 26% got worse than before treatment. Now, this indicates that while Tepezza can be highly effective for some, it may not work for everyone, and in some cases may lead to worsening symptoms. The pros. Go ahead,
Can I
John.
ask you some questions?
Yeah.
So number one, so when they had so they have a good effect. I mean, first of all, Tepezza advertised like crazy. Every single patient I have that has thyroid disease or even thinks they might have it, they'll say, "Do I have TED?" I'm like, that's a new term from the commercials. I mean, we used to call it thyroid overtopathy. But having said that, so if they get a good effect, because I mean, obviously we've seen patients with good effects. There's some great stories. If they do start to regress and it starts to come back or be worse, if you give them more therapy, does it help? Or that's it? Like they're not sensitive to it.
Right. So it hasn't been around a real long time.
Yeah.
Roughly 2 years, but patients have had a second treatment regimen,
Okay.
and it's helped. I don't know those numbers though, to be honest.
Okay.
But remember, this stuff is very expensive, over $350,000 per treatment regimen. Okay. Now it's over a 6-month period, but that's a lot of money. And when you compare it to a bone decompression, a 3-well bone decompression that we do, which is much less expensive, you have to do a cost benefit analysis for yourself. Okay. Now, don't forget, other side effects include hearing changes or hearing loss, and they have to weigh that into your decision making and your consent. There's a number of factors. Now, it is an amazing molecule. Let's face it, it's an amazing molecule for a difficult disease, but there are other elements to your decision making process that need to be factored in.
I look at like steroids. When we used to give steroids for thyroid overtopathy, it did work, but then a lot of times you had to give another, it came back later on. So the disease doesn't necessarily get cured. It just gets controlled. I guess what they don't know is how many treatments is it going to take, or is it going to be something that needs to be done once a year? Yeah, I mean, so that's the unknown right now. Is that what you're saying?
Right. And that's what post-marketing data analysis is going to show us. So we have to wait for that data, that 5-year data, the 10-year data, but
also I think one thing I would just point out, because at the beginning you had a great intro, but my understanding for years has been 20% of people that have thyroid eye disease do not have hyper or hypothyroid. So it's basically a different. So the way I've always looked at it, and I explain it to my patients, is there's these antibodies. Some people have autoimmune disease. They can have vitiligo. They can have rheumatoid arthritis. And they could have thyroid disease, which is circulating antibodies that go and they mess with the thyroid gland. And then for some reason, some of those people, even though they have those antibodies theoretically circulating, it doesn't affect their gland, but it still affects their orbit. So it looks like they have thyroid eye disease without having the endocrinological issues. Is that correct, Carl?
that is. So hyperthyroidism, roughly, it's about 65%. There's maybe 25-30% are hypothyroid, and you can still get it.
The rest is normal.
And the rest are chemically euthyroid. So there's Hashimoto's in there, which is a little different too. But so you don't have to always be hyperthyroid to demonstrate thyroid eye disease or Graves' orbitopathy.
That's one of the mistakes a lot of endocrinologists make, patients make. I've had patients refer to me, or I've seen them, and I see clinical symptoms of thyroid eye disease, like you said, proptosis or limited range of motion with double vision. And I'll send them to their medical doctor to say, rule out thyroid disease. And they say, they don't have it. I said, no, we need to do a CAT scan of the orbit. That's the only really definitive way to diagnose thyroid eye disease. You need to see inflammation along, the tendons and not the muscles, or the muscles and not the tendons?
No, the muscles.
So the muscles are not so it's a very pathognomonic CAT scan done, or MRI, where you can see thyroid eye disease even with normal thyroid levels. So I mean, if you're a doctor out there watching this video, you should keep that in mind, that just because your patient has normal thyroid levels doesn't mean they can't get thyroid eye disease.
Right, right, right. And some of the markers include something called a thyroid stimulating immunoglobulin, which
Yeah,
is a great
TSH.
marker. But a CT scan or an MRI to look at the muscles, particularly the inferior rectus and the medial rectus, will help you if you have a clinical suspicion and you need to get some more support for your
Yeah.
diagnosis. But really good stuff. Anyway, I do want to say Tepezza is an amazing drug, but discuss it with your endocrinologist, your ophthalmologist to decide if it's right for you. But kudos to Rosenblatt at Journal. This article was really interesting, and I look forward to more data, again, post-marketing data analysis to really guide our patients with more accuracy and precision. John, thanks a million for being here. Thanks to everybody. Please share this, like and subscribe, and we will see you on the next one.